So I was in the shower, I was cleaning my ass and making all sure it's all sparkly, spanky clean.
I'm not the funny one, I'm the pretty one.
Cock shots. I just checked myself out.
Candles, music, wine, and then lube up and get on top.
The glory hole's like a dick theater. I've imagined your friend.
Which means your pants had better come off. Mama needs playtime. I do this.
We're not sluts.
We just love love.
Hello, this is Angela.
And this is Bradford.
Welcome back to another episode of By the By. We are joined by two guests.
Yeah, we're not alone.
I know. Exciting.
Yes.
Would you like to introduce yourselves? We have Deb and Christy.
Yes. Who's going to go first?
Oh, you go first.
Oh my goodness. Okay. Well, I'll introduce myself as well because I'm the person who has introduced us to Bradford and Angela. Mm-hmm. My name's Christy Newman. I'm a friend of Bradford and Angela, and I also work at UNSW. I'm an associate professor there at the Centre for Social Research in Health, which basically means I do social science research in and around all kinds of health, but particularly sexual and reproductive health, gender and sexuality, bloodborne viruses, and those kinds of very interesting areas. And my colleague Deb is here. I've brought her along.
Kicking and screaming.
By no means. Look, it's fantastic to be here. So yes, I'm Deb. Sometimes I'm called Dr. Deb, actually.
Ooh.
So I am a medical doctor. So I've had an interesting journey in my career, I have to say. So I've been the medical director of Family Planning New South Wales now for around about 10 years, and I've worked in this area of reproductive and sexual health for around about 20 years. So as a doctor in research, I work with Christy. I'm associated, I'm an adjunct professor at the Centre for Social Research in Health at UNSW, and I've got some other interesting appointments at other universities as well. So I've got a great, network of wonderful colleagues to do lots of research with. I worked for a year. It's the global medical director for Marie Stopes International, which was great. So that was overseeing safe abortion services and family planning services in 37 countries around the world. And I've actually spent quite a lot of time working in Africa over my career. So in fact, I actually worked in Tanzania. And I always get the decade wrong, but I think it was in the 80s. It would have been the 80s. And that was actually when people were coming into our hospital with Slim disease, and those were the very first cases of HIV without a name at that time.
Wow.
And in fact, when I came to Australia, I actually did my medical degree in Hong Kong. I came to Australia and I worked on the pivotal ward at St Vincent's Hospital, where that was in the 90s, where there were lots of deaths through HIV. So I've had a very privileged career, I have to say, but it's delightful to be working with Christy now.
It is, and look, and HIV has also been a big part of my own work as well. Actually, my introduction to academic life came through volunteer care work through Community Support Network, which was part of ACON, where we provided home-based care to people with HIV at that stage. In the late 90s, people were still dying. So it's been a pretty extraordinary thing to see how much that's changed, and really to be part of some incredible innovations in the sexual reproductive health space, but also seeing the politics change over time with increasingly open attitudes, but still, also quite deep, long and important reluctance to talk about sexual and gender diversity that we still see in our community. So, those kind of, there's much has changed, but also much stays the same. Yeah. So that's, I guess, the areas that we both work in.
It's true. And the interesting thing that's happening at the moment, which is fantastic, is just that recognition that you have to integrate the sexual with the reproductive.
Absolutely.
So before, there's been all this sort of siloing, and I'll sometimes talk about, perhaps women that I see and they have to have 4 intimate examinations for, one to get their well, it's no longer a pap smear, but their cervical screening test. then another one if they're seeing a sexual health doctor, and another one for if they're getting an IUD inserted, for instance. So there's all this fragmentation of care. But now there's a recognition that that is not the way to best deliver services. So to really bring it all together, so that under this umbrella of sexual and reproductive health and rights, actually, which is fantastic.
Absolutely, and that's really where we have shared interest and interest in working across universities, clinical, and also with the community organisations that help support the communities who are living life in their own ways and exploring sexually and in lots of other ways, and thinking about, how do we work with those communities so they can stay safe and keep their partners safe. And I guess that's partly why we're talking to you guys.
That's the best introduction that anybody has ever self-given on our we're official now.
We're very professional.
It's amazing. It's like there's so many questions just listening to you guys talk about just your background, and I'm thinking, wow, we could just do a whole podcast on this.
That's true.
Regular contributors to By the By.
So I guess kind of where I wanted to start out was, it was interesting when you were just talking, Deb, about the
Dr.
silo.
Deb.
Dr. Deb.
I'll call you.
Well, when you were talking about the siloing of care, and I never really thought about that. It never really occurred to me, I guess, because I typically have seen one doctor for my pap smears, and then also same for getting birth control and whatnot. But I never thought about at some point that could be siloed, and that just seems so difficult to get the right information and between everybody, and to know what's going on with your own care as well.
So, and to touch on that, as the resident male here at the table, the male identifying person at the table, what do you mean by siloing? Are you saying that like a lady might see different doctors to get different things?
Yes, and some of that may be her own choice, of course, because she may be choosing to go somewhere other than her regular GP for something more...
Like for STI testing, because they...
Exactly.
Okay.
But what we do need to do, and there are some great models in Australia, I have to say, as well. So, but certainly some great models overseas. In Scotland, there's this fantastic integrated service where under one roof, there's transgender services, there's abortion services, obviously other reproductive health services, sexual health, HIV services, and so it is that one-stop shop. And I think it's certainly something we can have a look at and make sure it is all about just making sure that we are providing, patient-centred or client-centred, consumer-centred services for people. So and not having that siloing effect. So and I do a lot of work. We train a lot of GPs, and now in fact what we're wanting to do is to actually enhance the ability for GPs to be able to offer medical abortion, for instance, as well. So we know that that's not happening very, very frequently, as well as being able to put in IUDs, as well as being able to put in implants and deliver PrEP, for instance. So it's about supporting GPs, because that's where the majority of people in Australia go for their healthcare, and it's making sure that they do feel supported in that general practice.
So what's like the main hurdle that's standing in our way of doing this?
Yeah, so sometimes it is policies and it's funding and it's all of those sorts of things. So it's about being able to have good policies that actually allow that to happen. So I think sometimes if you go to a sexual health clinic, they may not be funded to do cervical screening, for instance. So that woman then has to go somewhere else to find that extra service. They may not be funded to put in an IUD, so that doesn't happen. So, but the conversations are happening now, which is really great, and there's a real recognition that we've got to make this work for people. So
because definitely. The worry, of course, is the missed opportunities. Yes. That if somebody is presenting and is talking about one area, that we need to not miss the chance to then ask the important questions about the linked things which may be missed otherwise, because people don't necessarily know themselves. They're also really busy. We have some concerns about whether GPs themselves feel as confident as they could and should in certain areas, and certainly there are some topics, some procedures that may make them uncomfortable, may make them worry that they they might get something wrong. They might, legally, what is this? Thorny issues socially and politically and legally that do come up.
And is it also a case where if a GP doesn't do a certain procedure very frequently, then they're not going to have the confidence necessarily when they're doing it, but as they do it more frequently, that confidence is going to go up, but then how do you start that ball rolling?
It's the catch-22, isn't it? You're right. Yeah, so you're absolutely right. And at family planning, we run a lot of practical training sessions for GPs as well, so they can come and insert their IUDs in our setting and then hopefully translate that into their practice. But Chris, what you mentioned, Christy, is absolutely right. So in fact, I train medical students at Sydney Uni around how to talk about sex to adolescents, because we know that actually they can go through, sometimes medical students can go through their whole career and actually just not have the language. They just actually can sometimes lack that language to be able to then put that into practice. So, but again, there's recognition that communication is the absolute key.
Because clinicians are humans too. Yep. They come from their own cultural backgrounds, their own religious backgrounds, their own family environments where they're largely are often difficulties in talking frankly about sex.
Yes.
And so, assuming that clinicians are going to have those skills, particularly in relation to some of these more socially contentious areas, I think we need to assume that everybody needs that support in learning how to do that more robustly.
So how do you teach a clinician to talk frankly and openly about sex, I'm assuming sexuality and sexual health? I mean, that seems to me, I've met doctors.
Well, and sometimes we have a hard enough time doing that amongst our very personal, close relationships, and now you're trying to get them to do this with a complete stranger, basically.
And then also let the stranger open up to them. It's very clear that you were talking, Christy, about missed opportunities, that if I'm too shy as a doctor to talk to you about your sexual health, and you're too shy to bring it up to me, or if you bring it up, I put both my hands up and go, I'm not qualified to talk about that. That could be something that could be life-threatening for you if not addressed.
But we have to have so much compassion for how complex that is, that even so often we know that some clinicians can really be worried about offending the patient and can make assumptions really about what that patient will be willing to talk about, and also assumptions about the kind of sex that they're having, or there's all kinds of things that we're reading of each other.
It's absolutely right. So in fact, you asked how you teach about it, and it's interesting because it really is recognised in medical schools now that communication is as important, if not more so. In fact, it sits over everything than learning to do a pelvic examination, for instance. And it is about actually having the script, so giving the script and practicing saying those things and learning how to reflect language back, and so people role plays are an absolute sort of part of every sort of medical school examination now, and actually you get examined on that. And it's recognising, because we also train a lot of doctors who work in Australia who've come from many different cultural backgrounds as well. So, and again, family planning specialises in that. And so you've got, there's cultural attitudes, of course, and different beliefs. And so very important, as you say, to recognise. You made me think about, we did a study with older women, and I use that term advisedly.
Do I count?
We said it was over 40. I must have we made it. It was interesting. It was with a big internet dating company who were fantastic, actually. We surveyed all these women. Then we did it with men later on, actually. We surveyed younger and older, in inverted commas, women, and we were asking them about just use of condoms in new relationships and all the rest of it. And in fact, we found, perhaps not surprisingly, that the older women were more likely to have unprotected sex on the first.
No risk of pregnancy.
Yeah, well, no risk of pregnancy, but also just lack of information and that other thing of just not getting information when they went to their doctors. And there was some interesting research we found around just that research showing that doctors actually sometimes, if they were young doctors, they just assume that anyone over 40 was just not having sex. And if they were older doctors, they sort of felt a bit, embarrassed about bringing it up and feeling that, just didn't have that language for it. So it just revealed a real gap, which is actually being addressed now, which is good.
Yes.
Or maybe they thought, you're old enough, you should know better, kind of thing, as opposed to actually making sure that people do have the information. Because if you've never been presented with it, why would you?
Yeah. I mean, I can definitely see both sides of that. The younger doctors don't want to offend the inverted commas again, older patients, and then the older doctors are admittedly, probably more prudish. So we're not going to bring it up. And if we don't bring it up, it doesn't exist. Let's stick our head in the sand and assume that it's...
Yeah, and a big span. And we also have to remember, I don't work in general practice, and I take my hat off to the
Absolutely.
GPs. They have a lot of competing priorities. And we're often... we talk about opportunistically bringing up about safe sex, etc. If someone comes in with a broken leg, it can be quite challenging sometimes to make that segue. So I think, we also have to be realistic, I suppose, about that sort of load that's on GPs. And I must say, I'm very impressed by all the doctors that come to us.
Absolutely. And really... very again kind of socially minded and really trying to understand where people are coming from, but there's a huge amount of pressure on them. I think of GPs a bit like teachers in terms of the number of things that we as a society expect them to be able to do, including how they get their responsibilities in shifting social attitudes and so on. It's a lot. Just one thing I was going to say, we interviewed different generations of people who identify as queer in the 3 parts of Australia from a study called the Queer Generation Study. And in the interviews with younger LGBTQ identified people talking about health services was absolutely fascinating. They had differently from the older generation, they had much higher expectations for the degree of inclusive care they experienced. The older generation still wasn't expecting that. The younger generation did. However, the attention that the younger generation paid to how the clinician was acting, how they were practicing, everything they did was absolutely, like, every single little thing was monitored. And it just made me feel absolutely that is fair to expect, but there's perhaps there's even more pressure on clinicians to get the sexual and gender politics right. Particularly around understanding the increasing diversity that we see, not only among younger people, but that times really have changed and they continue to. And there's a lot of pressure on clinicians to get it right.
There is, and we really have been very aware of this because we've set up a clinic. It's a cervical screening service with ACON for gender diverse people, and we've got some fabulous nurses, I have to say, working in this clinic and providing.
This is the checkout clinic.
This is the checkout clinic.
Yes.
And the staff there are marvellous. It's a wonderful space. But then, of course, we know that sometimes the people that go to that clinic, they're going to be referred back into our more general family planning service, or they may be referred to another specialist somewhere else. And we had to ensure that continuity of care, that everyone was actually working to the same standards. And I will say that there was a lot of education required, because it was a big shift, even for our very experienced doctors and nurses who've been working, with a whole wide variety of people of all different backgrounds. But there was still, just that bit of a jump and a bit of a leap to make, and I think you're absolutely right, and it's important, of course, we need to be forensically examined. I think that's absolutely right. But it is also good to recognise that it is challenging, and almost without exception, as doctors, I speak as a doctor, but just keen to learn those new skills and do the right thing by their patients.
And if anybody is interested in terms of a model of care, the checkout clinic is a really interesting one to look up at ACON, because of the processes that they put into place around really checking very carefully with where each client is at in terms of their preferred pronouns, their relationship to gender, to body parts, the things that they do and don't prefer in terms of processes. It's just beautifully done, and I just hope that really some of the principles will then be able to be used in helpful ways outside of that kind of quite protected space.
Yeah, and we'll put a link to the clinic in the show notes.
Fantastic.
As well.
Fantastic.
Yeah.
Fantastic.
Yeah.
So I want to touch on something that keeps coming up, a phrase that keeps coming up in the whole family planning clinic. I think, for us coming from the States, it's really funny growing up. Every time you heard family planning, that was always equated with abortion. And that it wasn't about sexual health. It wasn't about health in general. It was about abortion. And that was it. And it's really, I think that's something that whoever's behind the family planning and Planned Parenthood in the States has done a very good marketing push to show that it's that is one extremely small
Piece of the puzzle.
piece of that very big puzzle of sexual health and health for the LGBTQ community and for everybody. How is that in Australia? Is the mentality behind it similar, or?
So it's very interesting you say it, because I think certainly family planning, and there's a different family planning organisation across all of the different states. We're all funded a little bit differently, but there is an umbrella organisation. We basically do the same sort of scope. So its heyday, really, I mean, I'll still say we've still got our heyday, but things have changed slightly. Was really, I suppose, in the 60s and the 70s when the pill, the pill first came to Australia in 1961. And contraception was suddenly a thing that you didn't just, well, actually you did have to be married to start with. We had a stash of wedding rings apparently in our drawers, because you could only get the pill if you were married.
I love it.
But then things changed after that. But there were sort of a family planning clinic on each corner, as it were, and I know certainly when I talk to people perhaps in their 60s or so, they remember those days. What we do now is really, it's more around this training of other health professionals. So we do a lot of training for doctors, a lot of training for nurses, and so there are probably fewer services, but it's about putting the word out there. But interestingly, actually, some family planning organisations now are providing medical abortion, but the family planning services in Australia haven't actually traditionally been associated with abortion. That may well change in the future, but it's really been much more around contraception, but it's a whole heap of things actually. So, I mean, it is true to say that we don't see so many men in our services, but that is increasing. And it's really, we see people from adolescence all the way through to, the 90s. And so it's, just common gynecological problems with periods and those sorts of things, and infections and STIs and contraception and infertility and menopause and sexual dysfunction. So, also a whole range of different things. So I think it still plays a very important role, but people don't always know what family planning means, I have to say. Yeah. So, and I always remember there was a fellow fixing the family planning sign out of my window one time, and I heard him up the pole, and he shouted to his friend, he said, "Family planning? What's all this then? I've never planned a family in my life," he said. So it's quite funny. So there's been various discussions in the world really about, keeping hold of the term family planning, getting rid of it, changing it. But I think there's a renewed recognition that family planning actually, it has a strong history around that sexual and reproductive health and rights. It's good to grow it,
right?
rather than to say, let's call it something else.
That's right. Yeah, that's right. And it has got that strong history, and it does have brand recognition at this point, certainly in Australia. But look, linking, I guess, to the contemporary ideas really are about reproductive health, which includes choice, access, and issues to do with justice. So these are really important contemporary issues that an organisation like Family Planning is central to.
Yeah, so we do see, we have our priority populations. I mean, anyone can come in through our doors. You don't need a referral. Often people do get referred, and we've got a telephone line and a live chat and those sorts of access points. But we do have our priority populations, which are around people living with disability, for instance, young people. We also see people from Aboriginal and Torres Strait Islander background. So just, and COLD, of course, so people with from culturally and linguistically diverse backgrounds. And we do a lot of health promotion work. So I've just been looking at actually a menopause resource for women from Arabic background and other backgrounds as well. So it's a video to support women saying, look, if you're having terrible hot flushes, there's something you can do about them. So it's actually quite good.
So you do see people of all different ages there. When it comes to contraception, do you see a difference in the types of contraceptions being used and being chosen from in different populations, like teenagers versus people that are later life stages, or those that are in monogamous versus non-monogamous relationships? Like, do you see shifts and changes depending on the population?
Yes, there certainly are differences. I mean, we do collect some data around contraception in Australia, perhaps not. We'd like to up the ante with it a bit, actually, so we can drill down more to those population groups. But certainly, and I'm actually working, interestingly, with a researcher at Sydney University around Chinese women and decision-making around contraception. And it's been been very interesting because some of the assumptions I held have been found to be not the case, actually, which is interesting. But certainly, I mean, I always talk about, when I'm talking, and it's what Christy said around choice. I mean, what suits a woman when she's, say, 17 may be very different to when she's, maybe 26, or when she's 35, and when she's, 51. So things can change for an individual, but they also may vary between individuals at certain ages. But what we are seeing at the moment, actually, which is interesting, is just this increased awareness of what we call these LARC methods, the long-acting reversible contraceptives. So that's the IUDs, hormonal ones or copper ones, and the implants. And there's a global interest in these LARC, as we call them, because we recognise their benefits, and we're certainly seeing lots of young women, some teenagers coming in asking about LARC, which is interesting.
Yeah.
So do you think that that's because they're more aware of the options, or do you think that other doctors are pushing that more, or is it some combination of the two?
I think it's probably a combination of the two, but certainly, I mean, I've certainly been talking about LARC with my colleagues for quite a long time, and I think now you'd be hard pushed to find a doctor that didn't know the acronym LARC, and so we are certainly seeing a lot of referrals from other GPs. Perhaps they haven't learned how to put the IUDs in themselves yet, so we need to train people up. So I think there is increased awareness in the medical profession, but I think there's also increased awareness amongst, in this case we're talking about young women. There's some fantastic websites, some fantastic advocates in the community. I was thinking about Gina Rushton, who runs BuzzFeed, who does some fabulous articles. So I think young women are doing their research, and they'll often come in and say, "Look, I've been thinking about this, and this, but this is what I want," and we'll go make sure that we've got all the information about all the different options. But certainly, it's a combination. What do you think, Christy?
Yeah, look, I guess I'm immediately thinking about the more complex social issues that underpin some of those things, because as I tend to do.
Yeah.
And I guess one thing that we've talked a little bit about is that not everybody feels the same way about hormonal contraception, and there are, there's all kinds of interesting and important issues that we're looking at the moment around what trust means in terms of, medical interventions generally, but anything that involves a synthetic and a kind of that's something that's going to be interfering with your hormones. So natural approaches is the sort of idea that many young women feel like they would prefer, not only young, older women as well. And there's some concerns around that because certainly I think there's less evidence that kind of natural approaches, which includes things like relying on apps to predict your reproductive cycles and rhythms and patterns. And we know that people are engaging and using self-tracking and digital technologies in new ways all the time, and that's become increasingly a part of who we are, the way that we monitor and understand our bodies in relation to technology. We certainly would hope that that's not compromising their wellness, their well-being, and also their choices on the basis of what may be misguided fears about the safety and long-term impacts of these particular contraceptive options, because they're very well proven now over in many different settings. But my position is always to try to understand how people are thinking about things, because that's always fascinating and important, but also to make sure that we are asking important questions around why people might not trust in the medical advice that they're receiving.
Well, it's interesting because I've always been of the mindset that the IUD, that's a relatively new birth control, but it was developed in the 50s, right? And I didn't realize that until recently when Angela was getting hers replaced. Yeah. And the doctor said that, and I was like, I'm sorry, what? the IUD is nearly 70 years old now?
Yes, although we've come a long way with IUD.
Sure.
But they're not quite the same thing.
Sure, but I mean, it's just that mentality that as a concept, it's been around for a lot longer than we have expected. Yeah. That was sort of the one thing that I thought of listening to both. But the other one was something that, was it your grandmother said about the rhythm method?
It's quite possible. Where are you going with this?
I just heard you say it before, that your grandmother said that the rhythm method is the best way of spacing your children.
Oh,
Wow.
Yes.
Wow.
Yeah, so people often do talk about the rhythm method, yes, being... Anyway, there's lots of jokes around the rhythm method.
There are,
But
yes.
to talk about IUDs, and then I'm going to come to the... It is interesting because the IUDs have been around for a good long time, and in fact there was actually a particularly nasty IUD in those early days called Dalcon Shield, and it did and it was horrible, I have to say. It had a multi-filament thread and the bacteria could sort of climb up it, and it did cause very serious infections. There was a big class action in the States, and certainly women here also remember that. And sometimes I talk to young women and they say, oh, I'd like an IUD, but my mum says no, they're dangerous. And so we need to make sure that people do have that education, that evidence about the fact that we've come a long way, we've changed the approach to IUDs. And this,
we are critical consumers now.
Yeah.
We have access to so much information and knowing how to evaluate.
That's right.
And also that there's a lot of information on discussion forums among other young women and so on. That's a big way that people make decisions now. So and I like to have faith that people can navigate that in really creative and important and strong evidence-based ways also.
So it is hard, isn't it? Because certainly, many people will go on blogs and you can end up down rabbit holes, of course. And it's a challenge, and certainly we're seeing, this is anecdotally, but I think it's shown in our numbers as well. We're getting increasing numbers of young women who've made a decision to have an IUD, but they're choosing, they're choosing a copper IUD rather than the hormonal IUD. But then I do have to talk to the young women about it to say, look, your periods will be heavier and possibly a bit more painful with the copper IUD, but it has no hormones, so that's there's pros and cons with all things. And then the hormonal IUD, there's a small chance of hormonal side effects, but you're going to end up with light periods or no periods at all, and it's a little bit more effective in young women. So it's about making sure that the women do have that opportunity to sort of weigh it up and make that sort of informed choice. And that's a lot of what the training we do to make sure that it's, someone comes in and to say, oh, I'd just like a repeat of my pill, that it's not just a sort of quick repeat of your pill, that it's a chance to think about other things.
And because the options keep changing, so there are more options that the Nuva ring is a good example. I think of an option that many people don't know about, partly also because it's not on the PBS, but it is another option. It's a plastic ring that gets inserted right into the vagina, quite close to the cervix, I believe.
Matter, as long as it stays in.
Yes, and it gets replaced once a month. Yeah. So it actually, and it's very local. It's a hormonal based.
It's the same constituents as a pill actually, but it's just delivered in through that vaginal mucosa.
It's local rather than whole body as well. So that
it's actually working whole body.
Okay,
so
it is working.
It's still the same. The hormones are absorbed through the vaginal mucosa, and it's still having that same effect of stopping ovulation, and in fact it has the same side effects and risks and benefits as the
but you don't have to take a pill every day.
But you don't have to
sounds
take a
like
pill
the
every
efficacy would be better because you're not taking the pill every day.
Yes, and
no risk of forgetting. And isn't the pill also, some of the pills you have an hour or two buffer that you've got to eat or take them?
Absorption issues.
And you've got to take them on a certain time every day, and depending on what you've eaten, whether it's high fat or
so the
not.
Combined pill, you've actually got, the product information says 12, but we know you've got up to 24 hours. But the progesterone only pill, you've only got 3 hours. So that's the mini pill. Okay. And so that can be really hard. And we know that if you use it perfectly, the pill, it's over 99% effective. But in real life, it can be down to, now we've shifted a bit, so 93% is what we say. So that's 7 women in 100 becoming pregnant in that year of use. So whereas with the vaginal ring, you don't have to remember. But just to say, vaginal ring technology is so interesting. So there's lots of developments. So this ring you insert and take it out once a month, and now there's a new ring that's been developed through the Population Council in New York, which we were involved in some of the trials, and it lasts for a whole year. It's amazing. So women can still take it out once a month if they want to have what we call a withdrawal bleed, but they could potentially keep it in for the whole year and not have any bleeding. So they'd still take it out and wash it, but it's got enough hormone in it to last for a whole year. And there's all sorts of exciting things going on with this ring technology, the vaginal ring technology, because you can also put things like antiretrovirals, so anti-HIV medications in there.
Wow.
All sorts of things. So it's very interesting.
Quite a lot of interest in that for certain parts of the world, particularly Africa, but also others where access to some of those prevention technologies has been complicated by all kinds of structural issues. Yeah,
they call them multi-purpose technologies, or MPTs, where they're doing more than one thing. So they're delivering contraception as well as preventing HIV.
That's fascinating.
So it is fascinating, isn't it? So, but we need a lot of, there needs to be a lot of funding and will to get it going. But it is interesting. But I was just going to mention about we'll call it the sort of, it's not really the rhythm method, but natural family planning. And you mentioned an app, Christy, because there's been a lot of global discussion about this, because a Swedish company developed this app, contraceptive app called Natural Cycles, and it was the first app actually to be approved or registered in Europe. And there was a lot of furore. What it does, it's got a predictor. After putting in your sort of data over a certain number of cycles, it then has a predictive algorithm to predict when when it's red for no or green for go. It depends which way you're using it, of course, whether it's to plan pregnancy or to prevent pregnancy. And interestingly, it came under scrutiny because there were more pregnancies than they anticipated. And it was so interesting because what they found out was that some of these pregnancies, actually, it was people were just using it in the different days. So, it didn't take into account that sexual behaviour. So even though it says red is for no, sex was still happening at that time, and that's when actually those pregnancies were occurring. So it was actually quite interesting. So I think there's a lot of interest in this, but we have to let people know. And there are various apps which aren't approved in Australia, I have to say. So it sounds very exciting, and just because it's an app doesn't make it any more effective.
And beyond that, it's just like any other sort of prophylactic, in that you're not gonna, if you don't use it right, it's not going to be usul.
Absolutely.
If you've got the condom box sitting on your nightstand, they're not going to prevent pregnancy.
Exactly. So that's where the LARC methods are quite, they're interesting, because they are. So I actually don't like the term very much. I have to say set and forget.
Set and forget.
It is interesting, because the other thing that actually does have quite an impact, there's lots of different reasons, I suppose, that women will choose, or people will choose one method of contraception over another, and the effect on bleeding patterns is another important determinant.
Absolutely. A major motivator.
We just got pointed at. Christy's like, apparently this is a hot button.
This is a major.
I think this is a really important one to be thinking about in terms of sexual cultures as well, and sexual cultures where, bleeding for a certain amount of time a month might have an impact on the plans that you have. And so I think there are certain populations for whom reducing the number of days or the amount of time that you bleed is a strong motivator.
It's a consideration for sure.
Contraception choices,
It's interesting, actually, because we forget, really, that, many years ago, in years gone by, women actually had very few periods in their lifetime because they were either pregnant or breastfeeding much of the time. So far fewer menstrual cycles. Whereas now, in fact, with fewer children and less breastfeeding or no breastfeeding or no children, in fact, you have many more cycles. And in fact, we do know that seems to be associated with, for instance, the increased potential risk of ovarian cancer. So that incessant ovulation. And we know that the pill, for instance, can actually reduce the risk of ovarian cancer and reduce the risk of cancer of the uterus as well. So we often think about the risks of contraception. We don't always think about the benefits.
Yes. But that's what's interesting, isn't it, to challenge your ideas about what natural means? Because there's a lot of women for whom not having a period can feel quite confronting.
Absolutely.
Because they feel like this is my cycle, this is my rhythm, this is how I know I'm well, and so on. And that's absolutely fine. But also, yes, we live in a particular socio-historical moment and place, and the things that we think of as natural are actually really shaped by the time which we live, particularly for women. We haven't really had generations of women historically as they are living now, in terms of the kinds of lives that we lead and the kinds of choices that we have. So I
think it is interesting, because now as doctors, as health professionals, we're just raising that awareness that there's no harm to be done in taking a pill continuously, for instance. And there's been a lot of media on it recently, because suddenly realised that there was no good reason when the pill was developed to actually have a 7-day break. And in fact, a 7-day break is a bit bonkers, actually, because in that 7-day break, it puts a woman right on the edge of being just about to ovulate again. So if she forgets to start her new pack, or is late starting a pill, starting that next pack of pills, then she's at risk of pregnancy. So now all the newer packs of pills have actually got 4 days, a 4-day break. But of course, some have 0 days.
Yes.
But of course, I certainly know, just having worked in this area for many years, even if I explain that there's nothing, women worry about blood building up inside. They think, look, there must be something bad happening here, the blood must be building up inside. And when I explain that actually the lining of the uterus is getting thinner and thinner, and there's no bleeding because there's nothing to have a bleed with, they still prefer, some women will still prefer to have that regular bleed, and it's just, for them, it feels like it's a cleansing process.
Yep.
It's horses for courses, and
Right.
it's, as long as people understand, and can make that informed choice.
That's fascinating, and it's funny, Christy, you were talking about the choice to not bleed due to your lifestyle.
Yes.
And it's something that has always amazed me, because I was raised in a culture in the States where a woman's period, you basically don't touch her. Almost as if there's something dirty or unclean about it.
Yeah.
And the women that I knew in my past, that's the way they treated themselves. When you were on your period, there was no sex, there was no I don't even want to touch you kind of thing, or which was them towards me as well. Yeah. And then I meet Angela, who is. And I'm going to be crass here. I'm going to apologize.
That's okay. We can handle it.
Early on in our relationships, I'm getting ready to go down on her, and she looks at me and goes, "I hope you like the taste of pennies." And I'm like, we're like mid-sex, and and at the time that was a bit mentally confronting, but then her comfort level with it, and the fact that she was like, it's just something my body does, made me a lot more comfortable with it, which I think has really, it's helped our relationship. But on top of that, it's that ability to talk about it as if it's not something dirty
shameful.
or shameful or unclean.
I think there's really interesting work happening at the moment about menstruation and how it signifies, and the kind of gender relations around periods is fascinating. So much more work to be done. Yeah. But the cultural conversation has begun, and I see that more and more are really around period sex specifically, but more generally, why do we bring those assumptions to what is such an ordinary part of our world?
It's been a great taboo, and I still see many young women who really, they can even struggle talking about their periods as well as, vaginal discharge and all those things which are perhaps a little bit more taboo to talk about. But I agree, I think there's a much more open discourse now. People know about menstrual cups, for instance, and period underwear, and that conversation is out there. And I always have the barometer of what can I say on the ABC radio. And literally a few years ago, I remember actually recently there was one where I was talking, it was a lovely program, talking about vasectomy, and they said, we better make sure this is put on late at night, because it's going to be very, very challenging. But certainly periods you could not have talked about in daytime radio, and I think that's actually changed.
And that's a wrong mentality to have, especially about something. It's not unnatural.
And the word that you used was shame.
Yeah.
Right.
Yes.
So and we have to also again have kind of recognise that this really depends on the particular cultural, religious, social place that you've grown up with, and the values that you have, that your family has. But any opportunity to try to reduce our assumptions about how shame is associated with sexual reproductive health, with bodies, with sex, I think is of benefit, including in relation to gender, but not only.
But you're absolutely right. That concept of shame is interesting, because I was talking to one woman who didn't have periods, using contraception, but then there's another woman I'll talk about as well. She felt shame about that, actually. That was actually
about
shame
not having
in her culture. That was symbolising being a woman for her. So that was just something that wasn't working for her, and other people I'm thinking of are where women, it's a very distressing diagnosis sometimes, is to have premature, we used to call it premature menopause, but premature ovarian insufficiency is what we call it now. So for women in their 20s and 30s who find themselves in that situation where they have got this sort of, we'll call it premature menopause, it can be a very, very confronting around what it means into not just fertility, but just that embodiment of what it means to be a woman for that person.
It's interesting for me. I have 2 pre-adolescent girls that I'm raising, and thinking about how I'm very carefully trying to introduce ideas about how their bodies work and how they'll change, and really trying to prepare them for the ways that their bodies will work at this point in history, where we have to be really careful about not shaming, not attaching shame and so on. But yes, I mean, there will be many young women who actually don't have many periods potentially in their lives because of contraceptive choices.
And
so that's
and
a
the future
different
of
world than the one that
contraception,
I came into puberty through. And so it's interesting again thinking about parenting choices and how you advise and support through that.
But the designers or the people who are thinking about contraception in the future, you're right. I mean, it is so important that they actually, and I know this is happening, but is actually listening to the users of contraception to actually know what they want and how we can actually provide contraception that people want to use, because I think contraception also has had a very poor history, of course, in terms of human rights. So we've also, contraception's been used to control people's fertility, and sometimes at the level of whole countries, of course. We've had the one-child policy in China, but there's been also mass sterilizations in India, and certainly even in Australia there's been some poor history of abuses of contraception for young women living in institutions, for instance, given Depo-Provera injections without their consent. So we need to recognise those injustices of the past and make sure we don't repeat them, I have to say.
Absolutely.
So thinking about the future of contraception, it seems as though at this point in time we don't put a lot of responsibility of contraception on men. Do you see that changing? And as far as options that are available, people's willingness to go along with it?
I think it's a huge area of interest. In fact, the World Health Organization has highlighted it as an area that we really have to look at. So I think, as you say, there's been very limited options, basically vasectomy and condoms, and that's it. And now there's been some challenges along the way. We've got all the science to actually create hormonal contraception for men. There are some challenges with it, because sometimes if you give men hormones to actually knock out sperm production, what does it also do? It knocks out testosterone and libido.
Right.
So contraception in itself, but not desirable. So it's getting the balance right if you're going to use hormonal contraception. But we do have that science. But the problem has been, and we know that men want to use it, and we know that their partners want them to use it as well. So there's some differences we can talk about in terms of different types of relationships. But there's been just problems with getting the funding, getting the drug companies to actually sponsor and support these big, expensive trials, because they feel, look, it's not going to be a money-making thing for us. And there was a notable trial that got stopped. Australia was part of it. It was a big global trial on an injection for men, and it was stopped, and there was much ridicule in the press, because I think there was a relatively small number of men. They experienced, a bit of a painful arm and maybe a bit of a headache.
Laws.
But there were some other more serious side effects as well. But it's, again, it's just making sure then that you can actually go the next step. So I think there is a lot of interest in male contraception. There's actually one that may go, cross the line, is actually something called vasal gel, which is a reversible vasectomy. So it's little plugs are inserted into the vas deferens, that's the tubes that carry the sperm, and then you can actually dissolve those out if you don't want them anymore. So that's a good thing, isn't it?
Cool.
It's cool, yes. It's still only in animals at this stage, so we're hoping, again, it just needs that boost of funding to get it over the line. Because with vasectomy, certainly we've just started our vasectomy service at Family Planning, actually, and there's a big queue, I have to say.
We know we're in line. I actually have an appointment on Monday.
Oh,
It's not going to be with you, is it?
That's fantastic.
That would have been great.
That's fantastic.
So I'm actually really interested with what you have about to say.
Well, vasectomy, because it's been around for a long time, and there's actually an increase in the numbers of vasectomies being happening around Australia at the moment, which seems to be a bit of a global move. So that's interesting, a renewed interest in it. So it's very simple, of course, just under a bit of local anaesthetic. It's very, very sort of low trauma. But the key thing with this is you do have to see it as irreversible. Mm-hmm. So even though you can say, look, that we'll always, when I'm on those radio programs, some men will ring up and say, oh look, I got mine successfully reversed and that was great, but you can't predict whether that reversibility is going to work for you, because it's very expensive sort of microsurgery, putting all the tubing back. Sometimes there's another technique that can be used, but there is something called anti-sperm antibodies which may affect the chance of pregnancy later on, and you just can't guarantee that that's going to happen. But it's a very straightforward procedure. You've got to have the bag of frozen peas handy afterwards.
You're the third person who suggested that exact thing.
Can I just add something
Sure.
about vasectomy? Because I find vasectomy fascinating.
You can hold my hand if you want.
Yes, can I take notes? Look, it really is bonkers that more men don't take up vasectomies. So that sounds very judgmental. It's just at a population level, it would appear to be one of the simplest, safest, most reliable options. And so, of course, we know that this does reveal the reproductive burden being largely on women's shoulders. That responsibility is seen to be that contraception is a woman's job. However, I think it's a little more complicated than that. And there's some New Zealand colleagues, Gareth Terry and Virginia Braun, who've done a really interesting study on vasectomy there. They've got one of the highest rates of vasectomy in the world. So they were looking at men, like, why? Like, what did it mean? But the fascinating thing, they've got this concept of contraceptive economies, which is basically saying that there's various economies which are circulating around contraceptive choices. So some of them are around access issues, and some of them are around gender concepts, like things that kind of shape how we see choices and what we take up and what we don't. But one of the economies that they were describing is they called an economy of gratitude, which meant that any involvement by men in engaging in reproductive choices and decisions was worthy of additional praise. So there was really this sense that this is kind of a heroic act. And so even the men for whom this was straightforward and not a problem, they still kind of came with a sense that I'm doing something a bit different. I'm being a good partner. I'm being a responsible parent often as well, and a good citizen. So, I think we have to be a little bit careful about how we engage men.
I think that's
because the point is not that they get additional praise. The point is that we can all be contributing in useful ways to the right contraceptive options being available. Yes.
Yeah, no, I think it's interesting actually, because there are big differences between different cultures around vasectomy, and I know Papua New Guinea, for instance, has quite a high rate. Who would think of it? So, it's and it does seem to often come down to having those champions. But those champions, it is often their byline is that heroism, as you say.
Yes, it's really interesting.
It is interesting, and certainly certain cultures and certain religions actually will also, that it's not permissible actually in certain religions. But there's also a lot of mythology around it as well, and we know that some men can feel very anxious that it's going to have an effect on their sexual performance, and things might be different afterwards. And certainly you do need to, for us running a service, we need to just be very confident that people feel that this is the right thing, that we're going to minimise any regret later on that might happen. But there are different. I think there's a lot of interesting things behind it.
Yes, and lots of really interesting ideas about masculinity, virility,
Oh,
responsibility.
Yeah, and it's funny. That's it was something that I've wanted to do for a while, and we've had a number of doctors look at us and go, "Why? She's on the IUD."
Oh,
and sure, I get that, but then we're like, well, we're also non-monogamous, and I don't want, little Bradfords running around by accident.
It's because it's not going to change the fact that I'm not going to get rid of my IUD, and we do use condoms with other partners. It's just an added bit of insurance.
Yes.
And we don't want children, so it's not going to impact us whatsoever.
But
it can only help.
And have you found, and this is interesting to me because I've heard this anecdotally, that some clinicians can be quite concerned about your age and the decision that you're not going to have children.
Yes.
That
Oh my
you
gosh.
still need, that you almost...
You might want that option
That's
one day.
right.
You're going to change your
not
mind.
really able to make that.
Yeah, exactly.
full
I'm not
decision
mature enough
earlier.
That is a very common...
at over 40.
Yes.
I might still want kids. Like, look, I'm not Hugh Hefner, okay? I might wish I was.
Yes, but I agree with you. That sort of paternalistic attitude, I suppose it is. But it certainly, again, when on the talkback radios, that's certainly something that comes up, that people felt that they were told they were too young and they couldn't possibly do it. Although interestingly, it comes more actually from women who are. Maybe they've got 3 children, maybe they don't want children, but they want sterilisation, they want a tubal ligation. And I well know that it is very, very difficult as a young woman to get a sterilisation or tubal ligation in a public hospital or even privately. Very challenging. Easier for younger men actually to access the service. So again, I think there's some judgments going on there as well. So it's very interesting.
Well, I remember when Angela got her IUD most recently, they were even like, well, don't worry, if you decide you have kids, we can take this out. And I was like, but that's not...
No.
Yes.
I don't understand.
No.
Like, why does that even come up as part of the conversation?
Yes.
And this is my 3rd IUD, so A, I understand it can come out, but B, I'm on number 3 and I haven't wanted children in the past, 10, 15 years? It's probably not going to happen.
Yeah.
It's a cultural resistance to the idea of childlessness being a legitimate
It is.
choice.
Yeah.
And again, that's
It is.
another conversation we are beginning to have more,
We are.
but we have
We
so
are.
much.
And again, that comes
So
back to
far to
that,
go.
just training of doctors again. And,
Yeah.
we've got a whole new generation of doctors coming through who will be very cognizant of these facts.
Yeah.
But you're right, there is that assumption sometimes. And we are a bit of a pro-natalist society.
Yes,
we,
we are.
And I think it does
Yeah.
depend as well on how it's presented. Because if it's presented as, it can come out if you decide,
Yeah.
like, that's
Yeah.
fine, that's great. But if the doctor's trying to persuade you,
Yes.
that's different. So I think it depends
Yes,
as well
it's true.
on the tone of voice and how it's presented and,
Yes.
and that type of thing.
Yeah.
Yeah. So, cool.
I'll let you know how it goes. But
Well, I will say that one person, he did do his vasectomy on air on radio. So,
Well, so, honestly, we've already talked about asking the doctor if we could.
We were going to talk about it on the podcast.
Yeah.
If we could record it, that'd be great.
That'd be great. Because I'm more than happy, because it is something that I think it's important. And if it's a decision that more guys need to make.
And if they can see how it is. And,
And I don't expect, I'm used to shots. I'm type 1 diabetic. That's,
Yeah.
but yeah.
Yes, you can be a role model in this space, Bradford. I think you can.
It's interesting though, Bradford. I mean, what's your thought then around that sort of reversible vasectomy?
Look,
Interesting, isn't it?
I can see it as a great idea.
Yeah.
Because if somebody decides later on that, yes, I want to have children, then I can see maybe pushing younger men towards a reversible
That's what I was
vasectomy.
gonna
Yes,
say.
I think that's right.
Yeah.
And then, but somebody my age, like, I think I know what I want
Yeah.
at this age.
Yeah.
And at this point, it's not going to change.
Yeah.
Now, I admit, the only constant...
People change.
The only constant is change. And I understand that.
But you also get to know yourself.
Yeah.
And to be sure in that. And that's where
And
culturally we need to recognise that better.
And I can see, like you said, pushing younger men towards it because, especially, we've both had multiple marriages before, and it is one of those things that, like, when you're with one partner, you may think, oh, I don't want children. Maybe with another partner later, you might. But like you said,
I've got a story about that.
But over time, you do learn yourself a lot better, and you
Yes.
can suss out: am I making these decisions because it's what I want, or is it societal pressure on me?
Yeah.
And I think having that maturity, and for some people that happens at a younger age than others.
Yeah.
So I think it's good to have the option of the reversible vasectomy,
Yeah.
but it, you know,
Yeah.
but is it right for everybody? No, but nothing is right.
Nothing is,
Respecting,
yeah.
that autonomy. You're right. So,
Oh,
Christy,
well,
what's your
this is
story?
a very non-research based, although I have read it in I think one study, but this is anecdotal from a number of men that I know or I've heard from, that one of the main reasons they wouldn't do a vasectomy, even though they already have children, is that if in the future their current marriage ends, they want the option to repartner, and they're assuming that that new partner may be younger and may want children. And I find that quite interesting
Then the
and
question is,
a little
do
bit
they
difficult.
want more
I-
children?
I find
think
that
that's
very
right.
confronting.
And I think
You
that's
said it,
right.
not me.
So there are,
And because, of course, what that reveals all kinds of things about our gendered relationships and age and all kinds of things.
Yup.
Yes.
Back to Hugh Hefner.
Yes. But also that men will kind of presume that what they have to offer is also to be a father.
They're a sperm donor.
Absolutely.
Exactly.
And how central that is to their understanding of themselves.
Interesting.
Some
I think
questions about ideas about their current relationships as well, maybe. But
I think it's very interesting. So again, as doctors, we must make sure that we aren't jumping to conclusions, making assumptions, being judgmental. So there are a lot of things in that training around communication that are so important. Really.
Yeah.
I've got one thing I was
Ooh.
going to suggest.
Yeah.
So
Okay.
we briefly touched on the way that reproductive technologies have been used inappropriately. So we've kind of talked
Yes.
about sterilisation and how that's been used politically in terms of population control, but also in terms of intervening in the way that particular populations are kind of are managed. And we have that's been a really problematic part of the experience of many post-colonial nations, including Australia and its treatment of Indigenous people. So America has its own, controversies around sterilisation, and Canada. And I think it's really important that we recognise that the amazing work, in my personal opinion, that is happening in family planning and other reproductive health agencies today is also making sure that these technologies are not being used in the wrong ways, coercively, at an individual level, because we see reproductive coercion also occurring sometimes within partnerships. Deb, can you tell us about what that means?
Yeah, so reproductive coercion is increasingly recognised, and it can occur at many different levels. So, it can occur at the intimate partner level, but it can occur also, I have to say, at a health service level even. So I'll tell you what I'm talking about with that. But also at a country level or a policy level, political level. So I mentioned before about the one-child policy, of course. So that was, really women in China, after they'd had one child, they'd often have a stringless IUD inserted, which was designed never to be removed. So they couldn't actually have more children. So, and of course that's led to a big gender imbalance in the country. So, and then we know that, in other countries, yes, there's been, as I mentioned before, sterilisation, sort of camps, etc. In Australia as well, we've had, programs really which have been, the forced use of Depo-Provera. It's had a poor history, I have to say, Depo-Provera here as in many countries. And I know that, just as us as well-meaning doctors, sometimes I often tell the story actually of, I've seen many young women who've got contraceptive implants. And sometimes they don't like them. They want to have them taken out. It may be because they want to have a pregnancy. It may be that they've got side effects. But they sometimes tell me the story of going from well-meaning doctor to well-meaning doctor who just says, just keep it a bit longer. Whereas in fact, we were talking about autonomy before. That's because it would be not a good thing if you got pregnant, so keep it longer. And I must say, there's been, I'm going to say a terrible thing now, because there have been some, cases that I've seen where young women, and it is young women, have actually taken them out themselves with a razor blade. So, we must ensure as health practitioners that we're always just listening.
Coercive messages come in all forms, don't they? Some of them are about explicit forms of control. Some of them are subtle. That this is what you really should be doing because we think it's inappropriate for
and there's
you
a
not
lot of
to be.
awareness of that around LARC, actually, because the big LARC program, all the research came out of St. Louis in the States, in the Choice Project, and there are a lot of poor women of colour who were involved in those early research studies, and there was quite a lot of criticism, I suppose, about whether they were giving free LARC in this situation, and whether there was coercion going on in that situation, and there was a good robust debate about it, actually, I have to say. So again, it really raised that awareness of making sure I may think LARC's the best thing since sliced bread, but I need to make sure that I'm presenting it in a balanced way. But then coming to the intimate partners of reproductive coercion. So we're starting to ask questions of people that come into our service now, because we recognise that there can be coercion around using contraception or not using contraception, and we've had. We know that women can have their, contraceptive pills, confiscated. They can, not be allowed to come and get an injection. And we've heard of a couple of ones of a partner taking out a woman's IUD. And that's to control her fertility. And that also comes as well around sort of IVF service. I mean, I certainly see couples sometimes, and I need to always make sure I see the people on their own, because they're presenting as a couple, and there may well be an imbalance in actually who wants what, and sometimes there can be coercion involved in that, and that's the same for in fact in terms of ending a pregnancy as well, around an abortion. So we know that women can be forced sometimes to have an abortion or forced not to have an abortion. So it's just recognising this and really developing more or grabbing more evidence around this in Australia, so we can actually support women. And we do sometimes choose methods of contraception which can't be detected by a partner. So sometimes we will use an IUD with the strings cut very short, or we will suggest an injection which can't be detected, but of course the woman has to still come every 3 months, and sometimes that may be impossible for her to do that without being followed. So there's real awareness of it.
And I think that that's the difficult things to think about, and also I think a lot of people haven't thought about them. That coercive and controlling behaviours can apply right across a woman's life, or in any intimate partner relationship, actually, not just gendered. But what is wonderful is to see how many organisations like Family Planning are seeing this as a priority for them, in terms of, again, those not missing those opportunities to ask the right questions in the right way, to know what's going on, and also trying to link women, in this case almost predominantly, to services that can support them at the right times.
So how can people, like the general public, help organizations like Family Planning, Planned Parenthood, etc., etc.? What can we do?
Well, I think spreading the word is the main thing, because people don't always know about our services, and that they're open to everyone. So I think that's the key thing, is about raising that awareness, spreading the word. We've got a great website. There's different family planning organisations across the country. They've all got great websites. They've got really good,
lots of good
information sheets, and loads of, as you say, loads of good resources. So
in different languages as well, which is great.
Yeah. So it is just about raising that awareness, and we've got a fantastic telephone line, as I said, and a live chat. So and in fact that's proved very useful for young men, for instance, who in fact may find it really confronting to go and visit a doctor, but they can actually, they're happy to live chat or to speak on the telephone to someone. So I think it's it's just so spreading the word. So this podcast.
It is something that, I know Angela, her last IUD came from, was, I guess, inserted, I guess, from, sorry, words are hard for me.
I always want to say installed.
Yeah, I don't know why. Well, so my problem is I always want to call it an IED. That's different. Vastly different. So after I always say IUD, then I have no idea what, I'm like, did I use the right one? Yeah, okay, cool. But that was from Family Planning, and then, my appointment for the vasectomy is through Family Planning. It's something that we've always felt more comfortable, I think, going to Family Planning than our GP. Yeah.
Well, and we admittedly first found out about Family Planning at Sexpo. They had a booth one year.
Yes. And with Frank the elephant, I think.
Yes.
It's a very large inflatable elephant.
But that was where we first heard about it, and I was like, oh, so there is something around here, because we admittedly at that point hadn't looked. It wasn't time for my IUD to come out yet. I think I may have had one pap test at that point after we moved to Australia, but I wasn't really on a regular schedule yet. And so it was really good for us to find out about the services, and it was like, oh yeah, there's a place I can go and I feel comfortable, and that's good.
Yeah, and it's extremely important to have a space that you can go and feel comfortable in, and that you can rely on them, and that you ask questions and they give you good answers. And it's funny, it goes back to, Christy, what you were saying before about the hero thing. I always feel good about myself when I go to family planning. Like, you go there, you're supporting a part of the community that I think is either undersupported or ignored or misunderstood. And I think those three things are things that I fight for those that are undersupported, misunderstood, or whatever the third thing I said was. It's good to support them. Yeah. Cool. Well, we're gonna end this here and then come back to for more later.
Yes, exactly.
Woo-hoo. All right. Thank you guys very much.
Thank you.
You're
Great
gonna
conversation.
You're going to sit here and we're going to have another conversation. But, for the people at home, microphone people.
They have to wait a week.
At least.
Yeah.
But we'll talk to you guys soon.
Again, we would like to say a very special thank you to Dr. Deborah Bateson and Dr. Christy Newman for joining us this week in discussing reproductive justice. If you have questions or comments for either them or us, please get in touch with us via email at theatomsoflove@gmail.com, via Facebook, Instagram, or Twitter at By the By Podcast. If you would like to keep this podcast coming, help support us on Patreon, www.patreon.com/bythebypodcast. And you can also find us at our website, www.bytheby.com.au. Thanks for listening.
Hi, I'm Mr. Pent, co-host of Life on the Swing Set, and you're listening to a Swing Set Network podcast on swingset.fm.